Hello and welcome. Today we will discuss androgen agonists, antiandrogens, and male contraceptive drugs. This is an extremely important topic because androgen pharmacology lies at the intersection of endocrinology, reproductive physiology, oncology, geriatrics, sports medicine, and even emerging contraceptive technologies. So, let's start. The learning objectives are shown. Please take a look. Before discussing androgen pharmacology, we first need to understand the hypothalamic-pituitary-testicular axis, also called the HPT axis. This axis regulates testosterone production and spermatogenesis. The process begins in the hypothalamus, which secretes gonadotropin-releasing hormone, or GnRH, in a pulsatile fashion. GnRH stimulates the anterior pituitary gland to release luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH. LH acts primarily on Leydig cells within the testes. These cells synthesize testosterone. FSH acts mainly on Sertoli cells, which support spermatogenesis. Now notice the important feedback loops. Testosterone, and to some extent estradiol derived from testosterone, exert negative feedback on both the hypothalamus and pituitary gland. This suppresses GnRH, LH, and FSH release. In addition, Sertoli cells produce inhibin, which selectively suppresses FSH secretion. This axis is clinically extremely important because many androgenic drugs and antiandrogenic drugs work by manipulating these feedback mechanisms. For example, exogenous testosterone suppresses gonadotropins and may lead to infertility and testicular atrophy. Similarly, GnRH analogs used in prostate cancer suppress testosterone production by shutting down the axis. Now let us discuss the sources and metabolism of androgens. The testes are the major source of testosterone in males under the influence of LH. However, the adrenal glands also contribute weak androgenic precursors such as dehydroepiandrosterone, or DHEA, and androstenedione. Notice the enzymatic pathways shown in this slide. These enzymes are highly important clinically because many antiandrogenic drugs target them. The enzyme 5-alpha reductase converts testosterone into dihydrotestosterone, or DHT, which is a much more potent androgen than testosterone and is particularly important in tissues such as the prostate, skin, and hair follicles. Another important concept is intracrene androgen metabolism, especially inside prostate tissue. Prostate cells can locally generate active androgens from circulating precursors. Clinically, inhibition of 5-alpha reductase forms the basis of drugs such as Finasteride and Dutasteride used in benign prostatic hyperplasia and male pattern baldness. Androgens can broadly be classified into natural and synthetic compounds. Natural androgens include the principal androgen testosterone and adrenal androgens such as DHEA. Synthetic androgens include various esterified testosterone preparations such as testosterone propionate and testosterone sapionate. Esterification increases lipid solubility and prolongs duration of action. That is why testosterone sapionate can act for weeks, whereas natural testosterone itself has a very short duration. Some synthetic compounds have been modified chemically to increase anabolic effects relative to androgenic effects. These are called anabolic steroids. Examples include nandrolone and oxandrolone. Anabolic steroids favor protein synthesis, muscle growth, and nitrogen retention. Unfortunately, these drugs are commonly abused in sports and bodybuilding. Danazol is another important synthetic androgenic compound. Although it has weak androgenic properties, it is often used for disorders such as endometriosis because it suppresses gonadotropin release. One important clinical concept is that no anabolic steroid is completely free from androgenic effects. Therefore, virilization and endocrine adverse effects remain important concerns. Androgens act mainly through intracellular androgen receptors. Testosterone is lipid-soluble, so it easily diffuses across the cell membrane and binds to cytoplasmic androgen receptors. After binding, the receptor hormone complex translocates into the nucleus where it binds to specific DNA sequences called androgen response elements. This alters gene transcription, leading to synthesis of proteins responsible for androgenic and anabolic effects. Because this mechanism involves gene transcription and protein synthesis, androgenic effects are relatively slow in onset compared with membrane receptor signaling pathways. Another important point is that androgen receptors belong to the nuclear steroid receptor superfamily, similar to glucocorticoid and estrogen receptors. This mechanism explains why androgen effects involve widespread changes in growth, differentiation, metabolism, erythropoiesis, and sexual development. This diagram explains tissue-specific androgen actions. Testosterone itself is active, but in some tissues, it undergoes conversion into other biologically active hormones. The enzyme 5-alpha reductase converts testosterone into dihydrotestosterone, or DHT, which is more potent and has stronger androgen receptor affinity, especially in external genitalia, prostate tissue, and hair follicles. This explains why DHT is strongly involved in benign prostatic hyperplasia, acne, and male pattern baldness. Another important pathway is aromatization. Aromatase converts testosterone into estradiol. Although estradiol is usually thought of as a female hormone, it is also important in males. Estradiol contributes to bone maturation, epiphyseal closure, bone density, and libido. Now notice the tissue-specific effects. Testosterone supports skeletal muscle growth, erythropoiesis, and internal genital development. DHT has stronger effects on external genitalia and prostate tissue. This slide is extremely important clinically because many therapies selectively target these pathways. Finasteride blocks DHT formation, whereas aromatase inhibitors reduce estrogen formation. Understanding this slide makes antiandrogen pharmacology much easier. This diagram summarizes the broad physiological effects of testosterone and related metabolites. Testosterone influences development of male reproductive organs, spermatogenesis, muscle mass, erythropoiesis, libido, and secondary sexual characteristics. DHT particularly affects beard growth, sebaceous gland activity, prostate enlargement, and external genital development. Estradiol derived from testosterone contributes to skeletal maturation and bone health. Notice also the metabolic effects. Testosterone may increase LDL and reduce HDL cholesterol. It also influences body fat distribution and muscle mass. Another important effect is negative feedback suppression of gonadotropins. Exogenous testosterone suppresses LH and FSH release. This is clinically important because anabolic steroid abuse can lead to oligospermia and infertility. This slide demonstrates that androgen physiology is truly systemic and not confined only to reproductive organs. The most important clinical use of androgens is androgen replacement therapy in hypogonadal males. Patients with testosterone deficiency may develop fatigue, decreased libido, reduced muscle mass, osteoporosis, erectile dysfunction, and depressive symptoms. Various formulations are available. Transdermal patches and topical gels provide relatively stable hormone levels and are used daily. Intramuscular injections and subcutaneous implants may last weeks to months. Notice that oral testosterone is generally not preferred because of extensive first-pass hepatic metabolism. Androgens are also used in delayed male puberty when puberty fails to occur appropriately. However, testosterone therapy should always be monitored carefully because excessive dosing may suppress spermatogenesis due to negative feedback on hypothalamo-hypophyseal-gonadal axis and may also produce adverse cardiovascular or prostatic effects. Although androgens are considered male hormones, they also have selected uses in gynecologic disorders. Danazol has historically been used in endometriosis because it suppresses gonadotropin release and creates a hypestrogenic state. Androgens have also been used in postpartum breast engorgement and occasionally as adjuvant therapy in breast carcinoma. However, these uses are now relatively limited because of adverse androgenic effects and availability of better alternatives. This slide reminds us that endocrine pharmacology is not strictly separated by gender. Hormones may have therapeutic roles in both males and females depending upon the pathophysiological context. Anabolic steroids are chemically modified androgenic compounds designed to maximize anabolic effects such as protein synthesis and muscle growth. These drugs promote nitrogen retention and skeletal muscle development. Historically, they were explored in debilitating diseases and cachexia, but clinical benefits were often disappointing. Some anabolic steroids may still be used in selected cases such as hypoplastic anemia because they stimulate erythropoiesis. However, the major modern issue is abuse in sports and bodybuilding. Athletes misuse anabolic steroids to increase muscle mass and performance. Unfortunately, chronic abuse can produce severe adverse effects including infertility, hepatic toxicity, dyslipidemia, mood disorders, cardiovascular disease, and endocrine suppression. An important concept is that anabolic steroids suppress the HPT axis through negative feedback, leading to reduced endogenous testosterone production and testicular atrophy. Androgens can produce a wide range of adverse effects because androgen receptors are widely distributed throughout the body. General adverse effects include acne, hirsutism, edema, cholestatic jaundice, mood changes, dyslipidemia, erythrocytosis, and hepatic neoplasms. In males, excessive androgen administration suppresses gonadotropins, leading to oligospermia and testicular atrophy. Prostatic hyperplasia and possibly stimulation of latent prostate neoplasia may also occur. In females, androgen therapy may cause virilization. This includes deepening of voice, hirsutism, menstrual disturbances, and clitoral enlargement. One important clinical point is that some adverse effects, especially virilization, may become irreversible if exposure continues for prolonged periods. This slide highlights why androgen therapy requires careful patient selection and monitoring. Special caution is required when testosterone is used in elderly patients. There is concern regarding increased cardiovascular risk in older adults receiving testosterone therapy, especially in patients with underlying cardiovascular disease. The Beers criteria also identify testosterone as potentially inappropriate in some elderly individuals unless clearly indicated. Absolute contraindications include hormone-sensitive neoplasms such as prostate cancer, testicular cancer, and liver tumors. Pregnancy is another absolute contraindication because androgen exposure can virilize a female fetus. An important principle in endocrine pharmacology is emphasized here. Hormones are powerful systemic regulators and therefore require careful risk-benefit assessment. Now we move toward antiandrogens. These drugs oppose androgen action at different levels. At the synthesis level, drugs such as ketoconazole inhibit steroidogenic enzymes including cytochrome P45011 and cytochrome P45017, thereby reducing androgen synthesis. At the activation level, 5-alpha reductase inhibitors such as Finasteride reduce conversion of testosterone into DHT. At the effector level, androgen receptor antagonists block androgen action directly at the receptor. Cyproterone acetate is a steroidal antiandrogen, whereas flutamide is a non-steroidal androgen receptor antagonist. This mechanistic classification is extremely useful clinically because it explains why different antiandrogens are used in different conditions. For example, Finasteride is useful in DHT-driven disorders such as benign prostatic hyperplasia and male pattern baldness, whereas receptor blockers are important in prostate cancer. Antiandrogens are widely used in androgen-dependent conditions. One of the most important uses is carcinoma of the prostate. Prostate cancer growth is often androgen-dependent. Therefore, androgen suppression forms a major therapeutic strategy. Antiandrogens are also used in hirsutism, where excessive androgen action produces unwanted male pattern hair growth in females. Another common indication is male pattern baldness, particularly with 5-alpha reductase inhibitors. Some antiandrogens may also be used in patients with excessive sexual drive. Thus, it demonstrates how the same hormone may be beneficial in one context but harmful in another. Therefore, endocrine pharmacology is highly context-dependent. Because antiandrogens suppress androgen activity, their adverse effects largely resemble features of androgen deficiency. Common adverse effects include gynecomastia, testicular atrophy, and azoospermia. Gynecomastia occurs because reduction of androgenic influence allows relative estrogenic effects to become more prominent. Long-term suppression of spermatogenesis may also impair fertility. This is particularly important in patients receiving antiandrogen therapy for prostate cancer. The key principle here is that endocrine balance is delicate. Blocking one hormonal pathway often shifts the balance toward another pathway. Now let us discuss male contraceptive methods. Spacing methods are reversible and self-regulated. These include natural methods such as periodic abstinence and coitus interruptus. Barrier methods include condoms, sometimes combined with spermicides. Hormonal methods attempt to suppress spermatogenesis through negative feedback inhibition of gonadotropins. Several experimental methods are also under investigation, including lonidamine and retinoic acid antagonists. The major challenge in male contraception is achieving reliable suppression of spermatogenesis while preserving sufficient androgenic function for normal male physiology. Terminal methods include vasectomy and vas occlusion techniques. These are considered highly effective, but reversibility cannot always be guaranteed. The slide also mentions intravas deferens devices and RISUG, which stands for reversible inhibition of sperm under guidance. RISUG involves injection of a copolymer into the vas deferens that damages sperm as they pass through. One interesting aspect of RISUG is that it aims to provide long-term contraception while remaining potentially reversible. These emerging technologies demonstrate that male contraception is becoming an increasingly active field of reproductive pharmacology research. This slide introduces modern hormonal contraceptive approaches for men. Dimethandrolone undecanoate is a synthetic steroid that activates both testosterone and progesterone receptors. By producing strong negative feedback inhibition of gonadotropins, it suppresses spermatogenesis. Interestingly, it is not an aromatase substrate, meaning it does not readily convert into estrogen. Another approach involves topical combination gels containing Nestor-1 and testosterone. Nestor-1 is a progestin analog that suppresses gonadotropins, while testosterone replacement maintains normal androgenic functions. The basic principle behind hormonal male contraception is very similar to female hormonal contraception. Suppress gonadotropins and prevent gamete production through negative feedback. This table links clinical conditions with mechanism-based pharmacology, and demonstrates the central philosophy of endocrine pharmacology. Understand the physiology first, identify the pathological pathway, and then target the most appropriate step pharmacologically. In BPH, DHT-driven prostate enlargement is treated with Finasteride or Dutasteride. These drugs inhibit 5-alpha reductase and reduce DHT formation. Notice the important concept here. We are reducing DHT rather than eliminating testosterone itself. In prostate cancer, therapy often combines GnRH analogs with antiandrogens such as flutamide. The goal is both suppression of testosterone production and blockade of androgen receptors. In hypogonadism or delayed puberty, the problem is hormone deficiency, so the correct strategy is hormone replacement rather than suppression. In female hirsutism, excessive androgen action is blocked using drugs such as spironolactone or finasteride. Don't forget to like, subscribe, and share. Happy learning!